Welcome to part 1 of aging. This series of PowerPoints will focus on age-related changes and how they affect the care that we provide to our patients. Here are the learning objectives for the whole aging series. We're going to start by talking about middle adulthood. And middle adulthood is the age range of 40 to 65 years old. During this developmental time frame, internal and external physiological changes occur. Many people during this age range will mention that they start feeling older or looking older. Fatty tissue tends to become redistributed to the abdomen, and there's an overall increase in fatty tissue, along with a gradual decrease in muscle tissue and strength, making people in this age range look less lean, feel less lean. They don't feel as strong as they used to when they were younger. The skin starts to appear more dry and wrinkles start to appear. Hair starts to turn gray and may start falling out. Hearing and vision may start to decrease, and the use of glasses and hearing aids increases. Hormone production decreases, resulting in menopause for women and andropause for men. Menopause also causes bone weakening and bone loss in women. Cognitively, there are not many changes that occur during this age range that differ from younger adults. This age range still works. They have children, they may have grandchildren, and they have an increased motivation to learn and maybe even get a college degree or change careers completely. This age range can have an increased sense of personal freedom, especially if their children are grown and have left the house. They typically have more economic stability and have a set friend group, either socially or occupationally. According to Erickson, this age range is called the generativity versus stagnation, and they start to focus on guiding the next generation to become responsible adults. They start to accept and adjust to their own physical changes while adjusting to the changing of their aging parents, providing ongoing support for teens and adult children while simultaneously caring for aging parents presents a unique set of financial, logistical, resourceful, and emotional stressors for the middle-aged adults. This group also wants to maintain a satisfactory occupation, which means they may have to reevaluate their goals and accomplishments. This is why many people in this age group get degrees and change careers. Some employees in this age group have lost their jobs because of company downsizing during the recent economic turmoil and have had to acquire new skills and additional education to find employment in other areas. Relationships with spouses or partners may start to change, although for many at this time, the greater security and stability with stronger emotional commitment for sharing, and sometimes we have relationships change because of disenchantment. Either partner may develop negative or critical feelings and attitudes as a result of changes in physical appearance, changes in energy levels, or sexual needs and abilities. We see dissatisfaction with not achieving career or family goals, and this is going to contribute to the stresses placed on the marriage, and extramarital affairs and divorce happen a lot in this age range. There are many health issues that can occur during this age range. Some are modifiable and some are not. There's an increased risk for many different types of cancers. There's an increased risk of cardiovascular and cerebrovascular diseases and diabetes. Obesity, alcoholism, and liver and kidney disease are increased, as well as injury risks and arthritis. Diet, exercise, and smoking and alcohol cessation can help modify many of these diseases. With the increasing obligations placed upon this age range, depression and suicide also occur at higher rates. As nurses, we have a huge role in helping this age group decrease the incidence of modifiable diseases. Education on low-fat, low-cholesterol diets can help with the cardiovascular and cerebrovascular diseases, as well as some cancers. Regular exercise will help with obesity, injury, diabetes, and cardiovascular and cerebrovascular diseases. Alcohol and smoking cessation help prevent cardiovascular and cerebrovascular diseases, lots of cancer, obesity, diabetes, liver and kidney disease. And educating the middle-aged adult to keep doing their health-related screenings may help detect any diseases in the earlier stages so it has less impact. Immunizations are still important for middle-aged adults, especially influenza, and towards the end of this age range, pneumonia, and shingles vaccines. Now that we are through middle adult, let's move to the older adult population, which is anyone greater than 65 years old. This age group is growing quickly with all the advances that we have in healthcare being made every single day. Currently, 1 in 7 adults is an older adult, and this age group has tripled in the last 100 years. And Americans right now are living longer than any other generation, so they just keep getting older, and we start having more and more people in this older adult population. This age group is so important that it actually has its own healthcare specialty and research. Geriatrics is healthcare that focuses on the physiology, pathology, diagnosis, management of disorders, and diseases of the older adult. Gerontologic or geriatric nursing is nursing that's applied to older adults in all environments, including acute, intermediate, skilled care, or in the community. Any nurse can take care of geriatric patients, but some hospitals, like the hospitals on the far-reaching parts of the valley, have such high numbers of older adult patients that those hospitals truly become geriatric hospitals and have geriatric nurses. Gerontology is the combined biological, physiological, sociological study of the older adult within their environment. It's a field of science and research aimed to improve the quality of life in people in this age group. So whatever life they have left, let's improve it. Older adults are ultimately the age group that will die most likely at any time because of their advanced age. Over the past 100 years, the life expectancy, or how old we expect the average person to live, for adults has risen from 47 years old to 79.25 years old. This means adults are living almost twice as old as they did 100 years ago. There are many factors that can affect life expectancy, and we know that women live longer than men, and we know that certain races live longer than others. Socioeconomic and race ethnicity factors affect about 60% of the life expectancy variations. This is explained by differences in income, populations below poverty level, graduation from high school and college, and the unemployment rate. We know that older adults with retirement savings accounts live longer than older adults who don't have any retirement savings. Behavioral and metabolic risk factors, like those modifiable risk factors, account for 74% of the variation in life expectancy. This is explained by increases in hypertension, diabetes, obesity, cancer, pulmonary diseases, especially with things that are caused by alcohol, smoking, and decreased physical activity levels. Healthcare factors account for 27% of the variation in life expectancy. This can be explained by looking at the number of available healthcare providers in an area, the quality of services in the area, and insurance. If a person does not have access to healthcare, they can't be treated for their disease. If a person doesn't have insurance, they can't afford the medications and treatments needed to treat that disease. So what we see is those patients tend to die younger. There are many stereotypes related to the older adults, and it's called ageism. Some of these age-isms include the belief that old age begins at 65 years old. This is not true at all. Many people who are 65 and older are still working, still very active, and do more things than young adults do. There's a belief that most older adults are in long-term care facilities, which in Phoenix is definitely not true. There's a belief that older adults are sick and mentally deteriorated, but many adults live very active and productive lives. There's a belief that older adults are not interested in sex, and that makes me laugh because back in the early 2000s, Sun City Grand had their own reality TV show on E! Entertainment station, and those old people were very active, and they were active in ways that I would have never expected. There is a belief that older adults do not care about how they look and that they're lonely. This may be true for some older adults, but it's not true for all of them. There are so many activities and things for older adults to do now that many are very active and very social. There's a belief that bladder problems are a problem of aging, and that isn't true. Bladder issues are related to a disease process, not old age. There's a belief that older adults do not deserve aggressive treatment for illness, and this makes my heart hurt. Older adults deserve treatments just like anyone else. The difference may be whether or not the aggressive treatments are going to make the quality of life bad or not. We try not to do things that will cause a person to be in pain or suffer. And lastly, there's a belief that older adults cannot learn new things. Like that phrase, you can't teach an old dog new tricks. Those people have obviously never been to Phoenix during the winter months, where the older adults are playing pickleball and golf and gambling and sewing. I personally find that all these ageisms to be very wrong for the majority of the older adults that I have cared for, and this generation is my absolute favorite generation to care for. As people get into the older adult age group, the aging we saw with middle adults speeds up and becomes more pronounced. So I'm going to talk about each body system so you get a good idea of the changes we see in older adults. Overall, the body starts progressively decreasing efficiency of physiological processes, and in older adults, all organ systems undergo some degree of decline in overall functioning, and the body becomes less efficient. The integumentary system, being the outermost layer of the body, shows us instantly how aging affects the body. We see significant wrinkling and sagging of the skin occurring because of decreased skin elasticity. We also have increased dryness and scaling of the skin. The dryness and the decreased elasticity means we're going to see more skin tenting, so we need to be mindful not to assess skin turgor on places like the back of the hand, as they're going to tent all the time just because they're dry and don't have the elasticity. The skin cell proliferation slows down, so the skin layer gets thinner and more fragile, and subcutaneous fat diminishes, causing the older adult to be less likely to conserve body heat. Hair pigmentation may occur, it's going to start turning gray, and the hair will start to fall out. The musculoskeletal system gets affected by decrease in muscle mass and strength. Bone demineralization occurs, causing bones to become porous and brittle, and fractures become more common. Joint cartilage decreases, causing more joint pain, and there's an increased risk of falls with the joint pain and muscle weakness. The neurologic system responds more slowly to multiple stimuli, which is why the cognitive and behavioral response of the older adult may be delayed. The nerve conduction slows, so they don't physically react to things as quickly as they used to. The brain starts to lose brain cells, and the mass of the brain may decrease. There's also a decrease in cerebral perfusion, which could cause the older adult to lose balance and faint, which may lead to falls. There may also be increased confusion with certain physical illnesses. The older adult sleep also becomes affected by old age, and they are prone to respiratory problems, restless syndrome, nocturia, and pain that hinders sleep. The consequence of poor sleep on the older adult includes cognitive decline, in addition to what's already occurring, daytime fatigue, reduced physical and mental health, and reduced quality of life. As the older person gets older, special senses start to diminish in ability. Vision changes include diminished ability to focus on close objects, inability to tolerate glare, difficult adjusting to changes of light intensity, and decreased ability to distinguish colors. They become a greater fall risk in the dark as well. Hearing is affected in older age with a decreased ability to hear high frequency sounds that may start to affect normal frequency sounds. Taste and smell also decrease, so food doesn't have the same taste or experience it once did, and this may cause some older adults to eat less than they require. The cardiopulmonary system is highly affected by age. Blood vessels become less elastic and often rigid and tortuous, meaning twisting and turning like a coiled up string instead of being straight like a straw. This makes it harder for blood to get where it needs to go and leads to hypertension and heart disease. Venous return becomes less efficient, so we see more edema and venous insufficiency skin issues. The heart gets hypertrophied, which can cause heart failure, decreased cardiac output, and higher levels of stress on that heart muscle is going to take longer for them to recover from. So a simple walk for you and I that we recover from immediately, the older person may take a long time to catch their breath and feel like they're less fatigued. Orthostatic hypotension is also more common, especially if the person takes cardiac medications, which makes them a fall risk. The heart cannot decline without affecting the lungs, so we have respiratory issues as well. Lung mass decreases and their breathing is less efficient. They cannot take in and blow out a breath as forcefully as they once could. These age-related changes may be subtle and gradual unless they smoked. Smoking is the most significant risk factor for respiratory decline in the older adult. The gastrointestinal system starts having functional changes with digestive enzymes diminishing and nutrient absorption decreasing. The bowel motility, peristalsis, also slows down, causing slowing of gastric emptying and increasing the risk of constipation. The older adult has a decreased sense of thirst, smell, taste, and salivation, which makes them not want to eat, on top of difficulty chewing and swallowing due to tooth decay and tooth loss. Older adults require more nutrient-rich, healthy foods in response to alterations in body mass and a more sedentary lifestyle, and should be eating more protein, vitamins, minerals, and fiber while eating less fat. Unfortunately, healthy food is very expensive, especially for older adults who are on a fixed income. Budgetary constraints and physical limitations may interfere with food shopping and meal prep, so they may just go without eating. The genitourinary system gets affected by not only the kidneys starting to fail, but also with the bladder. Bladder capacity decreases by 50%, so voiding becomes more frequent, with 2 or 3 times at night becoming usual. There is also a decrease in bladder and sphincter muscle control that may result in stress incontinence or incomplete bladder emptying. The kidneys start to have decreased filtration rate, meaning waste and medications do not get filtered out as quickly as they should. The renal tubular function decreases, so reabsorbing and concentrating the urine is not as effective, and the kidneys are slower to restore acid-base balances and electrolyte imbalances. Men start having enlarged prostate, called benign prostatic hyperplasia or BPH, which makes urination difficult. Females start having relaxation of the perineal muscles, detrusor instability, and the detrusor muscle is the muscle at the bottom of our perineal area that tells us we have to pee, and urethral dysfunction, which can cause stress incontinence. Both genders start to become high risk for urinary tract infections, with women having the greatest and highest risk. Sex also starts to decline with the loss of a partner, primarily for women as a result of widowhood and for men as a result of poor health, erectile dysfunction, medications, and emotional factors. As the older adult ages, their intelligence and cognition does not change much, but the brain's ability to function properly does decline. This can cause changes in short-term memory, while long-term memory stays intact. There's also a decrease in reaction time, which increases the risk of falls, especially when combined with mobility issues, incontinence, and dizziness. Some older adults may have changes in cognition, with diseases like dementia, delirium, Alzheimer's, and depression. Psychosocially, self-confidence is relatively stable through the adult life. An older adult who has a strong sense of self-identity and has successfully met challenges earlier in life will probably continue to do so. This person substitutes new roles for old roles and perhaps continues former roles in a new context. They're not working anymore, but many may be playing golf, pickleball, sewing, or playing card games. Older adults have so much to adjust to as they get older. Not only are they dealing with the physical changes and declining health, they have to adjust to the changes of their spouse or partner and watch their loved ones and friends go through the same issues. This causes changes in social roles and caring roles, as people who are not the caregivers may become the caregivers. This causes a lot of stress and anxiety. Friends and loved ones start to die, which brings emotions and stress and even loss of income. Their support system starts to shrink, and they have less resources to help them emotionally, physically, and financially. Speaking of income, older adults don't have much income. If they're lucky, they have retirement savings they can live off, but many are not that lucky. They have fixed incomes, which means everything they have gets spent on housing, medications, and food, if they have enough for all of that. Food and medications often get missed because they can't afford both. As people age, they have more chronic illnesses that require medications. So they may be taking many medications for various diseases, and we call this polypharmacy, and it can be very dangerous. Not only are we dealing with the diseases, we have to watch for the side effects of all the medications they take, watch the drug-drug interactions, and make sure their bodies can process the drugs. The GI changes can affect the way the drug is absorbed, as well as a potential need for crushing and cutting pills. Nurses do a lot of education on not cutting and crushing pills that can't be cut or crushed. Drugs may be metabolized slower or faster depending on their lives and their bloodstream. The blood flow may alter the way the drugs are distributed to the tissues, and the decrease in liver and kidney function can decrease how fast the drugs are excreted from the body. This makes older adults at higher risk of drug toxicity at much lower doses than young or middle adults. Narcotics tend to take a lot longer to clear out of the system, and they may require much smaller doses to have less respiratory side effects. Some older adults may even have side effects that are not at all what we expect. Some people get sleepy on medications that should keep them awake, and some stay wide awake on medications that may make them sleepy. Education and knowledge is also an issue with polypharmacy. We need to do a lot of education on side effects, toxic effects, how to take the medications, and all of this is going to be affected if they have vision changes. We also need to make sure they're not taking the same drug twice. Many older adults are snowbirds, meaning they live in one place during the summer, and during the cold winters they move somewhere else. This means they may have two pharmacies, and both pharmacies can dispense the same medication. One bottle just might say furosemide, and one bottle might say Lasix, and the older adult will take both. And then they come to the emergency department in severe dehydration and electric imbalances. This also occurs if they have providers in two different states who don't know what the other is prescribing. Having a current list of all medications being taken is incredibly helpful for the older adults and lets the nurses and providers make sure they aren't taking the same medications twice. When assessing older adults, in a general sense, not a body-specific sense, we should focus on the spices, asking about sleep issues, problems with eating and feeding, incontinence, confusion, looking for evidence of falls and skin breakdown. Looking at all of these helps us understand how well the person is doing at home or wherever they're living, and helps us plan our care to best meet their needs. If they or their family members are unable to care for them at home properly, maybe we need to get them placed somewhere that can help them. Or maybe they need home health care or even Meals on Wheels to help them eat. There are many resources out there for older adults, but most older adults and their families don't even know where to start if healthcare workers don't tell them. As nurses, there are so many things we can do and should be doing to promote health in the older adult. Like I said many slides ago, this population is very special and is a specialty all on its own, so we do much more care for them than we would for younger patients. To promote physiological function, we want to help maintain the physiological reserves they have left, meaning don't let the problems get worse. We need to do ongoing assessments for early detection of problems, medication adherence, watching for medication side effects, and lab values. We also need to promote physical safety in the hospital and at home. To promote cognitive function, we need to speak and move at a slower pace and wait for responses to improve communication. We may need to have them wear their glasses and hearing aids and provide education materials at a much larger font size than normal. To help with psychosocial needs, we need to assess and support sources of strength, including cultural and spiritual values and rituals. We need to help reducing anxiety and agitation and watch for depression. Nutrition can be difficult to help with. We need to assess for lost or damaged teeth, but we can't fix those issues without a dentist. We need to ensure that their dentures fit properly, and we provide food that's appropriate for their ability to chew. Promoting adequate nutrition while keeping their disease process managed, like a DASH diet or a diabetic diet. Sleep and rest in the hospital setting is difficult to help as we function 24 hours a day and we have no issues waking people up all night long. If possible, We should assess for normal bedtime, normal time that they wake up, and whatever bedtime rituals help them at home, and try to stick to them as much as possible. To promote elimination, of course, we need to assess frequency of bladder elimination, as well as problems with incontinence, and help treat them as much as we can while also providing dignity. We need to avoid words like diapers with adults. Diapers are for babies, diapers are not for adults. Incontinence briefs or pads, much better terminology. Activity and exercise in the hospital setting may require assessment and treatment by physical therapy and occupational therapy to assess their ability to walk and ensure that assistive devices, such as a walker or a cane, are available. We need to promote balanced activity and rest periods, but also encourage the person to do as much for themselves as they can. We can assist as necessary with hygiene, hair care, oral care, clean clothing, bedding, makeup, shaving, while promoting independence. And of course, this doesn't only apply to the hospital setting. We need to make sure the person has all of the care and supplies to help them out at home. We may be required to set up care coordination with a caseworker or social worker to make sure all of their care and needs at home are being met as well. And this is the end of part 1 of aging.